my name's Ryan. This is a slightly different talk. I think I work in a space where technology, critical care, global health intersect, and we're trying to make it easier for those two worlds, or three worlds, or four worlds to blend a little bit. So I work with a technology development engineering team and physician team in Uganda. So on the left is my engineer, Patrick. I'm the other guy. We work with Adaptation. And then the Arctic is a physician engineer that we work with. We have several different partners, Massachusetts General Hospital in Boston, several accelerators, Harvard, MIT, the Consortium for Affordable Medical Technologies, which is a part of our global health group. Again, I'm Ryan. I'm the program director for Uganda for the Center for Global Health at Massachusetts General Hospital. So I spend 75% of my time in Uganda intersecting academia. We work with Adaptation. We work with the local teaching facility there, medical facility. And then I'm also a pediatric intensivist. That's my true trade craft. So every 3 months I come back to the United States and work for a month in my ICU. And then I'm on staff at Harvard. I have no conflicts of interest. I have lots of internal conflicts, but none of interest. But I want to talk about how to make breathing simple. And what are we addressing here? We're addressing MDG4, children who are dying. We're talking about in the millions, right? Now, I'm going to be talking about continuous positive airway pressure, or CPAP, and the direct therapy for children with respiratory distress, either neonates or children with pneumonia. But we're also been talking about how to maybe make this part of a bundle for children in extremis, as we call it in the biz, and children with septicemia or viral hemorrhagic fever, et cetera. And why are these little children at such tremendous risk? Why do they collapse their lungs? Why do they grow tired? Why do they fail? And why do they die? I'm not going to act as if we're on rounds and start asking questions, but let's just go over it real quickly. This is an energy depletion issue. Oxygen is a biomarker that we utilize. It's a demonstration reflection of shunt, and giving oxygen it helps fix the number, but it doesn't fix the problem necessarily. Someone else is going to talk about that in a little bit, and I'll probably get schooled. But we're talking about diaphragms that have type 1 fibers that are reduced compared to older children. So in neonates, much lower number of mitochondria. They don't have the stamina. That child, that neonate, was just deployed through a small opening. So they're quite cartilaginous. They don't have the bony structure to keep their lungs open. They are, so they have what we call a high closing capacity. According to Passoyle's law, they have a tremendous amount of resistance in their upper airway. We're talking to the 4th power. So if you add a little bit of edema, et cetera, there's a problem with their ability to breathe. Then their glucose stores are horrible. They do not have the glycogen stores that you or I have. In addition, their oxygen consumption, does anybody know? Compared to adults on a milligram per gram per unit time, is it the same as adults? A little bit more? It's twice as much on a good day. So if you add meconium aspiration, sepsis, dehydration, the child hasn't eaten. For them to eat, they need to breathe. If they don't breathe, they don't eat, and then they just spiral. So what's one of the simple ways to reverse this issue, keep their lungs open, conserve their energy, and keep them alive? CPAP. Now, CPAP has been around since the 1970s. We've had this around for quite some time. It's reduced mortality since the 1970s by 50%. And with many people in this room, with many of these different studies, we've demonstrated that CPAP and high-flow oxygen, and we can talk about the nuanced differences, have reduced mortality in various sectors in the global sector, and also by 50%. So what's the discussion? When bringing technologies into the global sphere, we're often talking about acceptability, adaptability, sustainability. So the current interventions are just too expensive, too specialized, they're not sustainable. My $30,000 CPAP machine that I get at my disposal in Boston, I cannot utilize that in other countries. So we have a lot of colleagues who have actually developed CPAP devices for low resource settings, but some of them are actually still around $1,000, $2,000. They're still extremely complex. They still require somebody has to know how to break it open and fix it. They're not freestanding. A lot of them actually require a lot of oxygen supply, either a generator or a cylinder. There's a lot of design, production, and distribution choke points, meaning areas where it makes it extremely difficult to build something for these developing settings and distribute them and sustain them. So, and these are great. There's some fantastic solutions on this page. There's the Pumani, which I think is fantastic. It makes me weep a little bit. It's a beautiful design. There's one by East Meets West, MTTS. There's the one by Diametica that utilizes an oxygen concentrator. I think they're fantastic, but they all have some they all have some challenges. Listen, I won't get up here and say I know I have the solution, but we have one solution. We call it simple CPAP. And basically, my team can build these in about 45 minutes. We basically buy in bulk the component pieces. We buy a high flow, it's actually an aquarium pump, but it's at 45 liters per minute. We regulate it through a flow meter. That's 1 to 10 liters per minute. We actually do a passive water humidifier. I don't use a heating element, and so we can increase humidification in the circuit by 30%. We use FDA-approved clear vinyl PVC tubing that can be cut out, replaced, washed, cleaned, etc. And you buy it in rolls. You can just keep building the circuits if you need to. Our PEEP, positive end expiratory pressure bubble CPAP apparatus, is basically a bottle with a pipe that's actually static. I keep the pipe or the tube at a static, maintained depth, and I change the PEEP, or the centimeters of water, by changing the depth and the level of water through a siphoning system. It increases, it enhances safety and accuracy. And the patient interface is the real trick. We actually use the RAM cannula from Neotech. This just came out the last couple of years. It's a relatively rigid loop. It's not like the old CPAP interfaces, which have about 8 different parts and are extremely difficult. And if you've ever worked with it, it's extremely painful. This group created this tool to interface with the child. What's missing in the picture? The box. That's not there. That's the choke point. If I want to take the guts of CPAP and build a circuit and then put it inside of a box, it's the box that becomes a choke point for a designer and for a distribution team. I have to have it specially made. I have to have it manufactured. And if I can't order it at magnitudes of 10,000, 100,000, it becomes a price issue. And then I put all those guts in a big box, and now I have a distribution issue. I just made it massive. And so we source that locally. We've already talked about using local plastic boxes. And so my team basically takes the guts, puts it inside a locally sourced box. Now I have an engineer who knows how to build it, therefore he knows how to fix it, and then we can make a whole bunch of them and put them together and have them in line, ready to be used. This is what it kind of looks like. This is another type. Some of these are prototypes. But you can see that we've changed the look of it. We've put it in smaller and smaller boxes, maybe the size of a shoebox, etc. But the circuitry stays the same. And actually, in anticipation of this talk, we actually sort of played around with the concept and just had our carpenter build a wood platform. It's the same circuit, same output, trying to make it somewhat relatively elegant, but trying to keep it this way. Our big issue is that we test this, and that's the big issue, is that we test it locally, make sure that the same output is produced every single time. And so whatever PEEP I put into it is the PEEP and pressure that I get out, whether it's 5 liters per minute or 10 liters per minute. We increase the humidity by 30%. So do I sell it as a kit? Do we put it online and make an open source discussion so that people working in the global sphere know how to build these? Do we manufacture and distribute it? Anyway, that's breathing made simple. Let's have a conversation. Thank you. Feel free to write me.
Thank you. Thank you, Ryan. You can breathe now. Two questions for Ryan.
Questions? I'm not scared.
One.
Now I'm scared.
And one. Okay. Thanks.
Yeah, sure.
Hi, I'm Monica, pediatrician from Norway. There's no heating in this system, right?
Correct. Yep. It's a passive humidifier. So we actually pass We actually pass the flow over to sterilized water, increasing humidity by 30%. This is something that we didn't do and some other designs don't have, but I didn't want to add a heating element. It's a tremendously complex part of the design, and it will break down, melt, stuff like that.
Thank you. Please?
Just to follow up on that, do you encounter any problems with rainfall in the system, that you have it condensates again,
no,
closer
actually,
to the baby?
Right, that's so yeah. So we call it rain out, rainfall, rain out. No, it's fine.
Is Sweden. Yeah.
Right. So rain out is when you fill the circuit with a really high humidified, heated amount of water. It starts to coalesce, and then you have spitting of water. And if you've ever seen a child, especially a neonate, hit with that spit, they sometimes pre-code, as we call it. They look pretty bad. So we don't have rain out issues because we keep it, the humidity, I can't get it to 100%. So no rainforest, no rain out, no, yeah.
Thank you. We will have more on that. Thanks, Ryan.